Hello and welcome to the Auditing Antics podcast. So I have to say, one of the things that Michelle and I get ourselves in trouble with is when we joke a lot and we're in situations where you need to be quiet or serious and you can't help yourself.
Yeah.
And Michelle really helped that along today by doing some interesting impressions before we went live. So now that's all I can picture when I'm looking at her.
Oh, geez.
All right. Probably added into that, at this point, Michelle, I feel like I've run a marathon today because everything that's going on with the government shutdown, telehealth. October 1st is a big day, anyways, in the industry because sometimes
Yes.
we have new policies that are coming into play. We have ICD 10 CM for us and PCS changes that are effective today.
Yep.
So, just a little bit crazy here. We'll try to keep it together as we go through the episode today.
For
Um,
sure.
Now, we are going to talk today about auto downcoding, mainly with Cigna. Aetna's also doing it.
Yes.
I believe some other payers are too, but I'm focusing more on where I've seen actual written policies. But before we dive into that, I want to talk a little bit about telehealth. So, this today is October 1st, 2025. And as of yesterday, we don't have resolution for telehealth. So, there's a lot of panic right now because we're going to be in this, limbo area of unknown, meaning
Mhm.
there's some people who think that the government's still going to come in and add a waiver maybe and extend for a little longer. Some are hoping that we'll see actual congressional action with them passing something more permanently. But as of today, here and now, we're in a place where the government shut down as of midnight, and the telehealth flexibilities that we had in place that were expiring yesterday, that actually happened. So a lot of people didn't think that it would. It actually happened, and there's a lot of impact for practices depending on how much telehealth you are offering to your patients. I have some clients that are almost completely telehealth now, others that are hybrid, some that are doing it out of convenience, which we know there's issues with that. But this is going to create a lot of chaos. So, one
For
thing I
sure.
will say, if you're watching this now or if you hear it later and you don't follow me on LinkedIn, go find me on there. Terry Fletcher and I have been collaborating quite a bit between our two consulting firms to get information out there. We actually announced today a new collaboration going forward, which is Healthcare Code Compass. Had to think of that. Um, so we're going to be working together to team up and get information out there, trying to be as thorough as possible, as up to date as possible. We did just have our telehealth event in September, and I have had multiple people emailing about that. It is available on demand, so you can go to stephanieallardconsulting.com and you'll find that we have it there. I'll put a link in here as well and in the show notes. But you've got to pay attention. I think, Michelle, one of the biggest things that's going to be impacting some of my clients is going to be the in person requirement, for example.
Yes, for
So,
sure.
with behavioral health, one thing that expired is that the patient has to be seen within 6 months of starting telehealth care for behavioral health or substance use disorder. And then going forward, they have to be seen once a year. And with the makeup of a lot of these companies, yes, they have a physical location, but there's one in a large state, and the
Mhm.
patients can't all access that one practice.
Yeah, and you also have to have the manpower to accommodate those patients coming in, because if you think about the scale of patients that they're probably seeing, even coming
Mhm.
in once every 6 months or once a year, that's a pretty full schedule still.
Yes. Yep.
And
Yeah.
I think that it's really unfortunate because also from like the patient side, telehealth did make care so much more accessible.
Mhm.
So it is kind of one of those things, like, from the patient side, it is a little, a little disappointing because not everything requires like a hands-on physical examination to monitor.
Mhm.
Obviously, there's things that providers can see with their eyes when they see a patient in person that maybe do not translate into into a tele
Touching the patient?
encounter. Yeah, like
Oh, yeah.
maybe they could see, maybe they're retaining some more fluid. I don't know. Maybe there's things that they can see better, but I just think about how much more accessible healthcare was through telehealth. But also on the flip side, it I don't think it was ever intended to be some type of like convenient, you can just sit here and blow through as many patients as you can in a day without ever having to have the overhead of that office building and things like
Mhm.
that. So I do think that there is going to be a rude awakening when, especially for these practices who have this 100%
Mhm.
telehealth model.
Yeah.
They're going to have to completely change their business model in order to be able to continue.
Yeah, and, that's one of the things. Telehealth as we've known it for the past 5 years or however long, I don't even know how long at this point. But telehealth, as we've known it during the pandemic, was pretty much all built on flexibilities and waivers. So that's
Yeah.
why we're going back to bare bones now. We're going back to what it was years ago when we told the majority of people, no, it's not supported. The
Yeah.
only thing that we have in addition to, those certain circumstances prior are some flexibilities that were adopted permanently for behavioral health.
Mhm.
So, we're going to have to see what happens with CMS. They've put some information out there. I'm going to keep paying attention. I know Terry's on top of it. She was texting me a bunch of stuff this morning. So, follow us on LinkedIn if you aren't yet. I'm just on there, Stephanie Allard. Also, look up Terry Fletcher, and we'll keep putting out information as we get it. But we will be in a holding pattern right now till we hear the final outcome from CMS.
Yeah. That waiting is sometimes the worst part.
Mhm.
You're kind
Now,
of.
yeah, exactly. Now, one thing I wanted to say real quick, and then we'll move on. With the telehealth on demand event that I posted there, that is one we did go through everything that was active prior to the PHE. So it does have information related to what that'll look like. If it stays like this, it reverts back, making sure that from a compliance standpoint what has to be in place, what you need to do, like Michelle, you're saying workflow, um, maybe even platforms if people haven't been listening to all the updates over the years, making sure you have your HIPAA compliant platform, a lot of different things there. So it's an hour and a half, has a lot of information. Definitely check it out if you're feeling that large component of unknown right now.
Yeah.
All right, so on to another frustrating topic of October 1st of 2025. So I really wanted to dive into this whole concept of payers that are auto downcoding. And, this is one Cigna put out their policy that was dated effective as of today. But we had, a comment put on this event saying, in their state, Aetna's been doing that to them for 6 months already. I know I have other clients as well that are dealing with that in different states, and it's pretty much happening from the perspective of either the payment is just a lower level, they're paying for say a 3 even though the 4 was billed, or they're auto downcoding it, like I expect we'll see with Cigna, and then it's
Mhm.
reflected on that remittance letter. But
Yeah.
either way, I see two sides to it, and we're going to break it down today. But either way, I have to say, the more that I go back to that Cigna policy and read it, the more frustrated I am, just based on the basics, right? So, those of us that work in compliance, regardless of whether you're doing coding, auditing, billing, whatever component inside or piece of this industry you're working in, we like to stick to the rules, right? We like
Yes.
to understand them in and out. We want to know the differences between and, or, should, required. All these little minute details really matter to us. And when you read this policy, it makes no sense whatsoever
Mm-mm.
based on the actions that they're going to take.
No. And it's like, how do you even how can they even accurately basically, they aren't putting any of the burden onto themselves. They're just essentially saying, if claims data tells us that it's not supported, we're going to downcode it and it's up to you. Well, what claims data is going to give you this information? Because
Hmm.
E&M relies highly on it relies on what's documented by the provider. So essentially that leaves you to the diagnosis codes that were
Right,
reported on the
right,
claim. And so it's like, because obviously there are bad actors out there. We know there are providers who blatantly do this incorrectly. Basically everybody has to be punished now. And Cigna is saying, we're going to put all the work on you to do that.
right, right.
So it's just insane to me that they can actually do this, first of all, because there's no real, in my opinion, can you really rely on claims data to know for sure that a level of service is supported? I mean, if now granted, if a claim is coming through with the signs and symptoms of fever, for example, and they're billing a level 4 or level 5, maybe. But where does it end? Like
Yeah,
where is the line for
yeah.
that? And I think that's what's really frustrating is, I don't know about you, but I have not seen any type of set parameters. It's just basically Cigna is allowed to downcode if they feel the claims data does not support the level of service billed. And I just don't see how that works with E&M.
Hmm. So, real quick, before I talk about that, I just want to point out for those not watching and just listening, Pam Vanderbilt also said on here that she's seeing Humana and UHC are doing this as well already. So, it's definitely happening. It's just we have this one in an official policy and started today. Now, with what you were just saying, Michelle, that's the part that really frustrates me because when you read the policy that they have written, they regurgitate the AMA guidelines that we
Hmm.
know. So they're
Yeah.
talking about the 2 out of 3 elements that are required. They're talking about time being another option that's available. And they go through everything that is strictly related to documentation and then say, which I think completely contradicts it, they say, if we feel that it's not supported, we're going to downcode, and then it's up to the practice to go ahead and appeal that. Now, they are saying, I think they said in that policy something like they expect it to be like a 3% of claims affected, a very low number, which I don't believe at all because we all know how this game works. And, the other part of that is when we think about, like you said, Michelle, the workflow and what it means for the back end. We already have clients that are not working the back end of the AR, or
Hmm.
how many people are using, and I won't name them, but certain billing companies or certain EMRs that require you to pay for billing support, but they don't work your back end.
Hmm.
How much of this is going to result in you not knowing what's going on? I still just a couple weeks ago met a brand new client who's in a situation where they have an external billing company and they don't have access to their own billing data. They don't even know what's going on. They're being provided one report that is a summary of receivables. That's all they know, what's being deposited into their account. They don't know how people are working their claims, any of that. So
Wow.
you have to be on top of all of this because it is going to be a revenue hit. It is going to hit your workflow. And, I do think we will have a lot of situations where this can be appealed and defended, but it's a matter of the fact that you have to do the work.
Yeah.
And there was another thing too in that policy where they talk about the ability, if you have so many claims that are overturned, if you appeal them, where you can, go to Cigna and ask to be removed off of this algorithm. Don't really know how that's going to work. I don't have a lot of hope there in things speeding up and happening, because that could happen in one day of claims.
Yeah.
So are they really going to process that much? Do they have the people on their side that are needed to be doing this accurately?
And who look at the whole prior authorization and you know peer-to-peer process where you're a vascular surgeon and an ophthalmologist is reviewing the medical necessity of your claim. Like, how could they even
Yeah,
begin to know, like, you know what I mean? So we know there's already problems in that side of things. And it's just
I
baffling
know.
to me.
It's
And
baffling.
one thing that really comes to mind for me is if you are an outlier, as in somebody who submits a high volume of, level 5s, level 4s, be ready, because I can guarantee you those are the first ones that are going to start being downcoded, because those are the easiest to identify
Mhm.
when you're looking, if you're an outlier. So this makes it even more important to be either performing internal audits or having an external audit done, and then actually taking those results and educating and being open to what those, outside auditors are saying. And actually, kind of, I know you and I have both seen it, where you have those problem providers where time and again you're providing education. What is the escalation process to this? Because now if you're having to spend the money to appeal every single E&M claim they submit, I mean,
Mhm.
even having to do that, like, what number do they feel to be acceptable to know, like, okay, we'll leave this provider alone? But if you are an outlier, or you work for a facility and you know who your outlier providers are, I just have a feeling those are going to be the first ones because they stick out already. And
Mhm.
those will be the first ones.
Yeah, well, that's just like I was talking with a rheumatology practice, and they're an outlier for fours, but their
Yeah,
fours are generally supported. That is their main level
exactly.
of service. So, it can be one of those things where the practice isn't going to have an issue, but if I'm looking at pediatrics and they're heavy on the fours, heavy on the fives, that's not really where they lie anymore under these new set of guidelines, and a
Hmm.
lot of practices still struggle to understand that.
Yeah.
So we're definitely going to have issues, and Pam made a good point here about combating this, making sure that we are actually talking to our physicians, our practitioners about, what we always do: free texted documentation showing us the full picture. What is the complexity or what is the severity of this patient from your perspective personally?
Hmm.
And, this is something that we continually have to talk about, but it's another example of how you're just being pushed in a direction where you're going to have to give into it and do what compliance is asking,
Hmm.
or what the coding team is asking, things like that. There's so many physicians and APPs out there where their first reaction to feedback or needing to work on something like this is anger, frustration. There's this one particular group that I work with, and the first thing I'm told is how many years they've been in this industry for and that I shouldn't be talking to them. And it's like, okay, well, it doesn't work that way. So we've got to focus on this to get things right. And, Michelle, there is a whole component. So I want to be clear here. I'm extremely frustrated with the payers. I don't think this is correct. Yes, there are times where we have fraud, waste, and abuse that are occurring, but
Hmm.
this isn't the way to approach it. This is not the solution to that particular problem, and them not being able to identify and, do whatever they need to do internally. So my key takeaway here is I'm really upset about that. But realistically, we need to talk about the part that the providers play into this, because there's a
Absolutely.
reason that the insurance companies are taking this approach. Whether we like it or not, it's happening because of the actions and, the incorrect claims that have been going out. And just in the work that I do more on the defense side, I see a huge uptick in investigations that are happening with many different specialties all across the US. And, with that rise, it's just more and more thinking, okay, well, these are, high risk areas. So what do we do to keep the money, hopefully not have to pay it out? Hopefully they won't appeal, all of these different thought processes. But for the work we do day in and day out that is preventative based, we know how difficult this has been to get people on the right side of compliance.
Oh, absolutely. Um, and it there it's a huge problem on both sides, I think. Um, we do see a lot of providers who do an excellent job. But like going back to what Pam said about telling the story in your diagnosis codes, unspecified, I I wouldn't be doing that anymore. You know what I mean? You better be documenting to the highest level of specificity that you possibly can, because that's how you're going to show the complexity of the patient. And that doesn't mean have your coders change a code to something like, how often do we see like E11.69, but then there's no other complication document. You can't just say other specified because nothing has been specified. You have to be careful of that. But is some of that going to start happening as a result of this? Are Is that going to be some people's answers to some of this? And some of that we already do see, Stephanie. I know you and I have both seen this on reviews in the name of HCC coding, reporting those more specific codes when that is not what the provider documented at all. They gave zero specificity. So we cannot report in other specified just because that holds a higher value or gives more specificity than unspecified.
Well, and Michelle, we were talking last week. You were doing some reviews where you had it was an audit of coders and the physician and APP practitioners. But there were situations where the coders were trying to like help it along. The
Yeah.
provider didn't give more specific information, but they're like, oh, the ear is red in this situation, or something's happened.
Yeah.
There's inflammation here. I think I can call this other diagnosis. And we have to be careful too with those of us that are working on that side, the billing, the coding and billing side. It's not our job to fix this for our providers. It's our
Absolutely not.
job to help let them know what is happening, to give them the hard data to show them,
Hmm.
what could happen, especially with this policy and others that are doing it. But it's not our job to fix this problem for them. We are not
No.
to be, and I can't believe I have to say this, but I've seen it. We do not document. You should have read only access to begin with. Nobody should be going in and updating things for that provider to make that more
Mm-mm.
specific. One thing now, I think we should clarify, Michelle, situations if there's a coder who's looking to submit a claim, if we have, signs and symptoms, for example, but they have documented a clear definitive diagnosis, then yes, we can follow ICD-10 guidelines, remove the symptom, report the more specific condition, and that's
Yes.
it. But outside of following what's supported in the note as is and our guidelines, we cannot touch this. We cannot do anything to
No.
help this situation.
And that's where we have to remember there has to be a clear distinction between our clinical interpretation of documentation. I think so many times, like there are so many things that just from personal experience, like I know a whole lot about diabetes. I know a whole lot about chronic kidney disease and everything that comes with that. I have to separate
Hmm.
100% of that knowledge when I am coding. Um, because I can't make assumptions. And that's essentially what you're doing. You're assuming. You are then diagnosing the patient.
Hmm.
That's not
Yeah.
our role by any means. So instead, you need to have a process in place where you query the providers. And I think a lot of times they don't want to do this, one, because of provider pushback, but also it slows down the process of submitting a claim. And with changes like this, and now, we're hearing about all these other payers, it's almost like you said, it's going to force them into these workflows, and it's going to force the providers ahead of time, because it's a whole lot cheaper to submit your claim correctly the first time than it is to go back and have to appeal it.
Hmm.
That takes time, and time is money, um, to appeal claims. So it's something to think about, that this has to be, of the utmost importance. But it also is kind of one of those things where it's always just been compliance.
Yeah.
So it's one
It
of those
should
things
be
where you
normal
you
to us,
you
but
should be doing this already. However, you and I both know it's not being done.
Mhm,
And it's just it's so important. And the thing that kills me is these EMRs and things, they try to give the providers the tools to make this as easy as possible. Um, but how many times are the tools either one, misused, or the providers just view it as clicks
mhm,
and don't want to do it, and they just, whatever, we're not going to do it. Um, and then it leaves it up to the imagination. um so yeah,
yeah,
there it's an unfortunate, it's going to be an unfortunate byproduct for providers that do this correctly, and hopefully their staff can quickly identify this as an issue for them, and then get those claims appealed and submit the request to be taken out of this policy workflow. But that's going to take time and money as well. So
mhm. Yeah, it's definitely going to interrupt revenue in one way or another. And, one thing that stood out to me that you were just saying, Michelle, was related to using tools and, making things as efficient as possible. And I understand that, there is a lot going on. And we do know, even though compliance is our main focus on this side,
mhm,
we know that our physicians and APPs are focusing heavily on their clinical care. Like, we are the
absolutely.
annoying thing on the side that has to be done. But I've had conversations quite a bit recently with administration inside of large organizations where their main focus 100% is making it easy for the providers, to the extent that they want to sacrifice compliance. And it's like, no, you cannot trade one for another. This is a
Mm-mm.
necessary evil of what we have to deal with. We all know that insurance in general and the way our healthcare system works is a game. We have to play it. So, right now, this is where we are. And the best we could do to help our providers, instead of saying, oh, take all of these shortcuts in the EMR because that's going to save you time, why don't you sit down and talk about the areas where they're inflating their notes with a bunch of
Mhm.
fluff that we don't actually need anymore?
Yeah.
There's a way to document what I would say is good quality documentation, meaning as an external reviewer, they can clearly see your thought process. There's a way to do that in a much shorter format than
Yes.
going on and on and on and on with a lot of extra information added in there. We should not need these notes that print out of an EMR 10 pages long. It's not helping this process. So maybe look to those other things that are burdensome and focus strictly on what's going to make a difference. You got to have balance. You got to have what compliance needs for coding and billing, and you've got to have compliance for the clinical quality. But there's a way to work together and figure that out that doesn't
Mhm.
require cutting out compliance completely for the claims that you're billing out. And
Absolutely.
this is something too where when I think about everything that's going to be happening, again, they say, for example, level fives will be adjusted to four, level fours will be adjusted to threes. The other thing I can't stop thinking about is when I work with a new practice and the practice administrator, for example, knows that their fives are not supported, or, someone down the line who doesn't have much authority or say in the practice knows that it's typically an issue, but they bill the fives anyways. That's also contributing to what has happened in this outcome. So you have to work internally in your practice first if you want to combat this, and you've got to make sure that you're staying diligent. Outside of that, Michelle, it's just every time I think about it, I get to a point where I have no more words, because when you look at the two sides, it's like you said, there's issues on both sides. Still can't believe that the insurance is using the base that they are, knowing they're not
Mhm.
looking at documentation.
Yeah.
And, you know, it just worries me that this is going to open up claim issues in the future in other areas if they're able to accomplish this, get away with it. We'll see over time what this ends up looking like, but it's really
Yeah.
concerning for what we're already dealing with in the industry.
What's concerning is what happens when their software fails them and they auto deny everything because we know it's coming.
Yeah. Yeah. I
You
know.
know what I mean? Like, where then you have to go back and look at not just E&M services, but what else did their lovely algorithm deny because somebody pushed a wrong button or flipped a wrong switch in their system, because technology is only good until it's not. Um, but it's only a matter of time before something ridiculous like that
Yeah.
happens.
Well,
Um,
and some have already been in trouble for, instructing their physicians that are employed there to open a claim, deny it. They've admitted they weren't even reading the information. Open, deny, open, deny. So with technology there, one thing I'll be curious to see, and we'll have to touch base, and hopefully people will talk about this a lot on LinkedIn, I'm sure. But I'm really curious to see as this progresses, what trend of diagnoses we see causing the downcoding.
yes.
If it's going to
Yeah.
be okay, if there's like how many would be a five. For me, thinking about outpatient E&M in a practice, I typically teach that those need to heavily be time-based because it's really hard to get it with MDM. So how
Mhm.
do they know? Just by the diagnoses, if there's five chronic conditions, that patient was stable and just getting refills, or they were, exacerbated, headed to the ER for evaluation. We
Exactly.
don't know that.
I do think that this is going to poke some holes in some people's time-based coding practices. You and I were just talking about this earlier, the frustrations that I have seen recently in some people's time documentation and how non-compliant it is. While they think, "Oh, I'm golden because the time supports my level of service billed," what they aren't
Yeah,
considering is on the back end, I've noticed this trend.
right,
And
right.
they're going to notice this trend too. So you're going to submit, and you and I know we've seen it. There's going to be providers where their 99215s are going to be down code and they're going to be like, "But I documented 40 minutes of time."
Yeah.
And they're going to
I
be like
spent
on
40 minutes and that's all
every
we have.
single every single patient 40 minutes. I don't
Yeah.
think you're going to win that appeal. Just letting you know. I
Yeah.
think they're I think some people are gonna have their bubbles burst just a little bit, um,
Yeah.
with the theory of time-based coding, but you are absolutely correct about those high levels. And also something that I wanna go back and touch on is related to the using the tools and resources available. This does not mean you need to start creating a template that says something about severity into your documentation that is now going to be on every single patient. Um,
The same
each
exact words.
each patient encounter is unique. So I cannot stress enough. You need to have unique documentation showing how you managed that patient, because The validity of that documentation is really taken away when I audit 10 encounters and 6 of those patients say they have hypertension, and it is the same documentation for each patient that has hypertension. You mean to tell me that each and every single one of those patients was exactly the same?
Mhm.
I don't buy it, and they're not going to either. And the answer is not use of more templates, because there is definitely um overuse of templates. And I can tell you, in the treatment plan and your assessment of the patient is not the place for the use of those templates. Like, that is not the intention. I know that I have just recently working on a project where I'm reviewing notes from this one provider, and it was one of those where it's like 10 pages long, and it's these giant blocks of documentation that is the same for all of the chronic conditions, and then down at the bottom, they finally write their plan. And that's all I needed to know. Like, all this other documentation that you put in here about like standards of blood sugar control, or what the standards of
Yeah, the clinical
blood
standards up there.
pressure control. It's like, that meant nothing. I need to know where the patient is at and what you're doing for it. Like, put that in your after visit summary.
Yeah.
You know what I
Well,
mean?
I can probably guess the EMR that they were using. I will not name it here, but if it's the one I think it is, I recently have a case that I'm having to defend, and I will say the documentation supports everything that was billed, but the reason they're having to defend themselves is because they're so highly templated and they have so many macros. And I know for a fact that that EMR system sells their product as
Mhm.
if it's going to help with efficiency. They back it saying that they have attorneys, they will be there if you have to, appeal. All of these things they try to offer from a legal standpoint, but they are the reason. The way that system is
Mhm.
set up is why they're having to submit appeals, and they had 100% denial. I'm very
Yep.
confident that we have good defense. I'm very confident the documentation is there, but I can 100% see why they ended up in the situation they're in, and nobody
Mhm.
wants that.
And I think that is going to become more and more apparent. And it also is kind of like a way for Cigna to get more information on them. So they start seeing more on your E&M, and they start noticing holes and issues within the E&M. So what are they going to look at next? Where does
Mhm.
it end? It's going to give them more eyes into the billing practices, where they're going to then start spreading that out. So I
Yeah.
it's
That
going
can
to be
open
a
a can of worms. Like,
that's
how
a
many
trickle
people
down effect.
how many people, for example, will bill out an E&M because they don't think they get paid enough for the procedure they're doing or things
Mhm.
like that? Yeah, it's
Mhm.
really going to open quite a few things up here for sure.
Yeah, I think it's going to be a little eye opening for
Yeah.
some, and then others it's really going to be an unnecessary massive burden for them. So definitely complete frustration on both sides. Like, nobody's a winner except for Cigna here, in my
Yeah.
opinion.
Yep, exactly. And the others that are wanting to do it as well.
Yep.
All right. So we will pause there for today. And I just want to remind everybody again, one more time, if you're joining a little late. So, with the telehealth flexibilities expiring as of last night, the ones that were extended to September 30th, we are still in a holding pattern. Later today or tomorrow, I'll get information out there from CMS. If you're on the different listservs, you've probably already received an email from them talking about, their perspective and what you can do right now while we're waiting to see what Congress does. But as of today, here and now, it is expired. So things have reverted back to what they were prior to the PHE. Also, one last reminder on my website, if you go to stephanieallardconsulting.com, You will find that there is an on-demand telehealth event that Terry Fletcher and I did September 18th. That is now available on demand for purchase. We did cover everything for an hour and a half related to what that looked like prior to the PHE, what you need to be aware of, all of these different things that are changing and how it can impact your workflow, all of those things. And one last thing as well. So I was talking to Michelle. We've really been growing the podcast quite a bit lately, which is awesome. I do ask if you go in any platform you watch on, you listen on, if you go in, review that, rate us, subscribe, follow, all of those things. It's going to help us grow even more. But I'm really excited about that because I know a lot of people can benefit from, just the conversations that we have here trying to get information out. So thank you to everyone that's helping us grow, and we will see you back next week.